A very good evening, everyone. This is Batul, the moderator for today's session from IJCP, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our stalwart who is present here with us today. Well, sir needs no introduction at our platform, but yet it's our great pleasure and honor to introduce him. He is none other than the very renowned Dr. T.N. Ravishankar, sir. Sir is MBBS, DFM from Colombo, FCGP, PGD MLE, MBA in Family Physician, Sudhar Hospital, Chennai. With Sir's wonderful insights, we are going to talk about the topic for today, which is the art and science of clinical medicine. And now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So, over to you. Please proceed.
Thank you. Thank you for the nice introduction and on this afternoon on a topic which is look very different, the art and science of clinical medicine. Clinical medicine is one which is now almost getting extinct. That we should also know what is meant by art and science. Why does medical practice involve art? Of course, we know this is a science. Science of medicine, science of human anatomy, science of human physiology, pathology, and so what, whatever we learn from the first year to the final year. But then there is something called art and science in clinical medicine. In fact, it is there in the entire practice of this medical profession, the art. What is meant by art? There is a definition for everything in the universe, be it in the language of English over the world, or be it in our own national language, Hindi, or in my own regional language, or whichever regional language there is some definition for art. We say that Mona Lisa painting was such a beautiful art. The artistic taste of that person had been reflected on the board that where he drew the Mona Lisa, which is there for years together. That's painting. We talk of my own name, Ravi Shankar Pandit, who practices the music. It's also an art. Such a beautiful way he plays the sitar, and everybody gets mesmerized for hours together and keep hearing it for years together. We still keep hearing it. We always talk about the beautiful cover drive or the lofted shot hit by Sachin Tendulkar or Virat Kohli. Two different contrasting players, but the end result was the 4 or 6 that happens. Artistic way how they play the shot. And that is there in almost every part of life we see it. We have a bachelor's degree in history, geography, political science, and so what in so many subjects. And what do they learn and what do they practice in their life? History. Whatever that had happened earlier is being taught to the student, and hearing it, they try to innovate something and put it down. Writing an exam is different, but learning the history or the geography or the political science that they learn in the college and then put it down in practice for their own well-being in their profession or in their occupation. That is where the art comes out. Somebody who creates from what he has learned or what he has experienced. It's a creative activity, produces a product, an object. Art is a diverse range of human activities in creating visual, performing subjects, and expressing the author's thoughts. The story is written by somebody, directed by somebody, and acted by somebody. Three people together produce a beautiful film, which we see for years together and enjoy sitting and hearing, seeing it. The product of art is called a work of art for others to experience. Whatever they produce, we feel it, we enjoy it, we relish it. And that is what is art. Creating, framing, and shaping is all its components. Art is good when it masters the aesthetic element and principles. The way how it is made and how it is looked is all coming from the inner feeling of the person who tried to produce this for you. In a successful piece of art, visual features are most important. The line quality, the color composition, and other artistic elements and principles. Somebody who wishes it within himself, in his thought and in his heart, and reproduces it for somebody else to see it, feel what he has felt when he was creating it. That is what is called an art. The art of speaking on stage is another great talent done by so many politicians, so many great people, and so many people who try to motivate the population sitting in front of them to follow what they say, what is the principles of life or whatever it is. And that is what is art. Somebody producing an original form from where they have learned it, might be experience or whatever it is. I think science is known to everybody. Being that we are in the science of medicine, we know it. It originates from the Latin word scientia, which means knowledge, knowing it. You have some data which are being assembled together, give something, the inference. That is where science is originated. It's a pursuit and application of knowledge, an understanding of the nature and social world following a systemic methodology based on evidence. Scientific methodology includes the following: an objective observation and measurements and data. Umpteen number of data that are assembled together find a solution. I have some clinical experience. If I keep talking about art and science, I think on this afternoon nobody will be able to keep themselves awake because we are somebody who are seeing the human anatomy, human pathology, and keep following what is happening for the system, then come to an inference. Art in clinical practice is clinical listening and advocacy of the skill that you have learned. And ultimately, it is the makeup of art of medicine. Communication is one major skill that we need to practice, is needed, which you need to practice is medical profession. Before that, we need to have a listening skill, understanding, and if we try to listen well, we will be able to get a clue for the diagnosis that we are searching for in the ailing patient. Active listening skills, ask open-end questions. We always ask a probing question after listening to the patient. Request for clarification. Somebody says he has got dyspnea. Then you ask for a clarification whether at lying down or when he is at rest or when he is walking or climbing stairs. That question can come if you have listened to the patient giving you the information that he has got breathlessness. He is not going to tell you that he has got dyspnea. He's a layman. He's going to say that he's got breathlessness. You need to be attentive. At the same time, trying to summarize the symptoms, whatever he say, paraphrase it, and then it is not reflecting the feelings. It is diagnosing the ailment that he is suffering for. But you need to know what is his feeling with the ailment and ask him more probing questions that are associated with it. Whatever questions that are associated with the ailment that the person is suffering is all science. Because our forefathers, our teachers, our learned professors who had been earlier practicing this profession would have associated so many symptoms, symptomatology, their variations together as science. And that science is now being mingled with the art of listening. Let me go to one of the most nicest case that I have come across, seen by one of the pediatricians in a two-tier city, my state of And this is a true fact of a patient that they have seen. In a government hospital, it has happened in a government hospital, you would have known what would have been the status of the patient. This was a 16-year-old female child who came with pain in the abdomen. They have been examining. The patient got caught in a pediatric ward because it was less than 18 years. They have palpated the abdomen, they found a big mass, and they did an ultrasound and found to be a suspected ovarian mass. Unfortunate for a child of 16 years old to have a mass in the ovary. There was discussion of what to proceed and how to proceed. And finally, they planned for an exploratory surgery. And you leave these patients to the surgeon, I think they would always be willing to remove the tumor that is there to prevent the spread of tumor anywhere. That point of time, the patient was sent into the anesthetist. The anesthetist postgraduate saw the patient in thorough. The patient was not fit and said unfit for surgery, noting that the patient has got a bradycardia somewhere around 42 to 45. This is where the science of clinical examination was so important. The patient came back to the medical ward, pediatric medical ward. They did a further evaluation and found out the patient was grossly hypothyroid. Naturally, not fit for surgery. Then they substituted the thyroid. Then again sent the patient again to the in 2 3 days, saying that the patient has been substituted with thyroid. Then the anesthetist there said, ask the patient to come back after 3 months once the metabolic changes that because of the long-standing hyperthyroid is changed. In a government hospital, if you have and did all the support for them, they will definitely come back after 3 months, and that too for a 16-year-old female child. You said there is a mass in the abdomen. So did they came back and they did an ultrasound. They found the mass has totally got vanished. The signs that in a hypothyroid patient, the mass in the ovary is a rare feature. That is that which has been proved earlier in so many papers and so many. Then they repeated the ultrasound. The tumor has vanished. The child is totally fine and normal. The child was sent back home. And in fact, the pediatrician have seen the child after another 6 7 years with a child. Fortunate on that day, examination by the anesthetist found out the patient has got a bradycardia, referred back for total evaluation. Otherwise, the patient would have lost her ovary. The chances of becoming fertile once she is married, or even getting married with a single ovary or without an ovary, which is practically not possible or going to be a very, very difficult proportion in this country or even in the world anywhere. The lesson learned in this was thorough clinical examination, which is in relation to the science, and communicating that bradycardia, convincing the patient, and making them come back after 3 months to follow up. And this was a case that has been presented in the respective departments for being recognized as one of the rare features in that. Here comes the communication skill and clinical examination for a heart rate which is low. There are 5 C's of good communications when you are concerned about the patient. When you want to put the patient for surgery, you have a concern that no complications should have. You are committed to your anesthesia profession. You are taking care of the patient totally with your competence, clarity, that your confidence was not overconfident. Child for a surgery when she had a heart rate of just 42. You had a clarity of thought that you do the surgery only when the patient is totally normal. The metabolic derangements that could have happened in the system or a long duration of hypothyroid, these changes could come back to normalcy in 3 months' time. Had they tried it even after a month, the mass would have shrunken And after 3 months, it was totally vanished. And that is how the child is alive with another baby in her arms, which is a commitment of this profession to the society. This is a classical example of a clinical medicine being very, very useful in day-to-day practice. The simple bradycardia had allowed the anesthetist to refuse the fitness and thereby making the child go on with a normal life, with a knife being put on her, losing an organ, becoming somebody who has difficulty in conceiving in the present era of infertility of high durations. This is where the effective communication, slide taken from elsewhere, assess what the patient already knows. Probably the child would not have had a case and that history would have not been elicited properly. Assess what the patient wants to know. Be empathetic towards the patient. Slow down, don't be too fast on certain things. This is how that bradycardia had resulted in the anesthetist trying to slow down the process and preserve the ovaries and the uterus. Keeping it simple without the medical jargons. Be true to the patient and transparent in all your communication with them. Be hopeful that they will follow whatever you say. And that is the art of this medicine. Watch the visual clues. That is what is very important. Even in a pre-diabetic stage, you have the acanthocytes nigrans. If you watch your patients regularly and examine your patients properly, look out for the new symptoms that can happen in them. You can easily detect a pre-diabetic state in the present era of India being the capital of diabetes in the world. Be prepared for reactions. Always the patients will have their own choice, their questions, and be prepared to receive the questions appropriately. And today, we always have a fixed idea. The patient walks into your chamber with the notes written down or have downloaded from the Google and asking you lots of questions. And Google is giving them an information. It is your responsibility as a medical professional, knowing the human system, to educate them appropriately. And that needs the art of practice of medicine. There's another clinical history. I think this case was seen by me only. This patient had admitted his son in a hospital for a fever of long duration. I was treating them for a viral fever with thrombocytopenia, reassuring them without any antibiotics. The father was repeatedly asking for an antibiotic, which I refused, telling them, you don't need an antibiotic for a viral fever. It takes time to settle. All you need is rehydrate, put them on paracetamols and vitamins if necessary. During the time when the patient was on the treatment, the guy was telling, I want to do an endoscopy. I find burning sensation behind the sternum whenever I walk and whenever I climb stairs. And I probed him some more information, and he said, when I walk a little longer, I get an exertional pain in the jaw. That is there for the last 2 weeks. He had said it. And it was dyspnea on exertion, class 2. It was there for 6 months. And he repeatedly was asking for an endoscopy. It's very clear. Now we know in this Indian continent, if you have a chest pain, burning chest, or whatever it is, they will never be able to accept that you have got a coronary artery disease. They always say it is the reflex esophagitis, gastritis, gas, and all these things they keep telling us again and again. But our textbooks clearly says you have a pain on walking, radiating to the lower jaw is going to be a coronary artery disease, particularly on the inferior wall. And I told the patient, I will do whatever you want. Once you subject yourself for a coronary angiogram, and then after the angiogram, we will try to do a endoscopy. And I have to convince him, say, if you have any problem in the coronary, proceed with the endoscopy. That might create a little bit of problem for you. And he accepted the same, and then he went in for a coronary angiogram. This was the ECG which was taken, which was not contributory for any inferior wall, but there was a little bit of changes, which naturally any patient would have correlated with the Google ECG, and that found out not being comfortable with whatever I have said. But then he subjected himself for a coronary angiogram. The right coronary had total occlusion, distal slow filling through the collaterals. That is why he could be able to walk. Once the collateral was not able to support it, then he had the pain, and more work, he had pain in the lower jaw also. This is classical science. This is evidence-based science, where you have done a coronary angiogram to show the patient what is there in textbooks. I don't see that this coronary angiogram was available 4 decades ago when I was reading my medicine. At that time, history, pain on exertion radiating to the lower jaw is always sufficiency. Classical, today we have an evidence-based medicine that it gives evidence that the patient has got a problem in the coronary, particularly in the inferior wall. And this is that evidence. And what is the art here? The merger of art and science. The science that our forefathers have given in the textbook of medicine, that inferior wall symptoms can be, and the art of trying to communicate to the patient that inferior wall, exertional get burn, chest pain, burning behind the sternum, radiating to the lower jaw is all now with an evidence-based medicine of coronary artery disease. And I use this slide very often to convince the patient who are not willing to undergo an angiogram. Whenever I suspect the patient has got a coronary, you see the left coronary also has got a problem. Stenosis in the proximal LCX, middle LCX, then the coronary after stenting, the two stents in the RCA, the patient was totally normal. And now today, the patient accepts the fact that it is not that Google that can give you the right information. It is that medical personnel who can always give the right of advice for the patient. That is where the art versus medicine comes into existence. Medicine can be considered a science due to its reliance on knowledge derived from in-depth research and testing. And that is what we have seen in that slide of coronary angiogram. In-depth research and testing. Lead to what is believed to be true in the field of medicine. What is true today might be foolish tomorrow. In medicine, truth has a shorter half-life. When I was doing my medicine, if I say I'm going to give an insulin in the evening, 7 o'clock, I'm bound to fail. I have to reappear again for my medicine theory as well as my clinics. But today, we have something called, and those days it was only the Benedict solution that we used to find out, because sending a blood sample from the ward to the laboratory and getting the results back is going to take 2 hours, 3 hours. Today, you have the simple glucometers, the growth of science, growth of biotechnology has given it. You can test it anytime, use the necessary insulin to keep the sugar under control. That is where the HbA1c is always there. And that is what is true today. In medicine, truth has a shorter half life. Things keep changing with the advancement of science, with the experience of the professionals that keeps things moving. In an art, because how well doctors and other medical professional utilizes this knowledge while interacting with patients depend on their expertise. And that is where you become more experienced with years passing on, that you try to deliver the best of advice to your patient. Art is not just a part of the medical activities, but is also fundamental to clinical medicine as applied science. That is where the communication is very important. Before you communicate, you need to listen and you need to develop the art of listening to the patient what he says. Medicine, merging art, merging with medicine. The study of medicine should be a scientific endeavor and its application an artistic endeavor. We learn that science so perfectly. You get the best rank, you get the top rank in the NEET exam, you are able to get a gold medal, number of gold medals, but then only when you can apply it in an artistic endeavor that you will be able to convince a patient, take the patient out of their ailment. And that one patient who is so satisfied your line of communication is bound to bring you more and more of patients to you whose recovery that you are going to relish as a professional. That is where you feel that you have taken the right profession of your choice. Application of art in clinical practice. The art of comfort and care remains a cornerstone of medicine, driven by millennia of common sense as well as a more recent methodological approach to medical ethics. Without these humanistic traits, the application of the current science of medicine is ineffective, harmful, or even harmful. Application of art. That is what we have to keep saying. Listening, communicating, and examining itself is an art. Examining a patient, standing on the right side of the patient is a very, very important aspect. You just cannot walk into a chamber or lie on the left side. When you are on the right, you are always right. That's what my teacher have taught me, and I keep telling them. When you want to examine the patient, make the patient sit up. When you are on the right side, he sits up on the right side of the cot. Everything is on the right side. So things can go always correct. And then when you are a right-hander, it is always comfortable standing on the right of the patient. More often, you are always a right-hander. And even if you are a left-hander, it doesn't cause much discomfort. Examine the patient, keeping yourself a bit away towards the left side of the patient. That's much more easier. That is where the application of the examining the patient with all the empathy and care. That's very, very important. It can always be a rough in handling a system, rough in handling a patient, but that is not going to make him feel confident. The softness with which you handle the patient, the tenderness in which you test upon an abscess that has been obvious or a mass in the abdomen, the softness which you take care is going to reflect on how skillful you are and how empathetic you are towards the patient, trying to find out the what is there beneath his skin. The art of feeling in clinical practice is empathetic skilling. And we have 2 ears but only one mouth, so we should listen more than what we say. Empathetic listening skill is a relaxed demeanor and a demonstration of an active interest in the patient's uniqueness are all characteristics of an excellent bedside manners. You know, there has been a study that was done. When a patient walks into your chamber, they try to give you we keep listening for a few minutes or a few seconds. Study that had been given in how many minutes or in how many seconds a doctor intervenes a patient who's giving a history. It is only 1.3 to 1.45 minutes that the doctor interferes in a patient giving a history. I think it is too short a time for any patient to give a history, unless if the duration of the ailment is a shorter duration. Even if the patient has got a shorter duration of history, he will always try to recollect something that had happened similar a year ago during a seasonal fever, or anything that would have happened to one of his relatives or his friends on a similar way that he would try to recollect. We always try to intervene at that point because we feel that is irrelevant to the line of management or the line of diagnosis. But when the patient feels giving that history might give a that is why listening for a clue. A similar symptom of his relative or a friend, a similar symptom that he has now happening in a system, the way how it started, how it progressed. These patients are too smart enough to find it out. They always try to recollect what friends have when they had their MI or when they went in for an appendix surgery, how earlier the pain was there, how was the pain, and all these things. See, whenever a patient visits a patient who has been a patient who had been admitted in a hospital, the attender, the patient, both of them are interested in wanting to share the information about the ailment that the suffering they had, about the symptoms they had, and how the doctor went about trying to diagnose, how the doctor advised to go in for an investigation. And they always try to give information to the next person Be it next time, if you do get a problem of this nature, ask them to do it directly to an MRI or a CT abdomen or whatever it is, rather than going to do a two-phase, because it involves expense, time consuming, and the end result is not known until the last investigation is done for. But then the art of science is there within the investigation according to the need of the patient. The art of hearing is there, very, very important, trying to find out where, what, and how the patient is suffering from. This is another science which I am trying to bring it out to you. A 45-year-old male, no comorbidity, he had been on seasonal fever. He complained of palpitation and giddiness in the ER. The pulse rate of 140. BP was not recordable. Respiratory system was clear, abdomen was non-contributory, and then everybody who had been worked in the ER will know what the diagnosis would have been. Patient where BP could not be recorded, pulse rate is very high, and they have put the patient on a monitor. It went up to 180, 190, and the ECG showed supraventricular tachycardia. It's a very, very easy diagnosis. Once the BP is not recorded, the pulse is recorded, the lungs are very clear, there is no crepitations or rhonchi is there. The whole history is very important here. The patient had a seasonal fever with cough, and if a seasonal fever and cough is there, everybody's first line of management is the over the counter getting a cough syrup and trying to take it. And your cough syrups, even if they may not have had an alpha stimulant or a beta stimulant or whatever it is, they do can go in for a supraventricular tachycardia. Getting a proper history of whether the patient had taken any cough syrup or any medication, or whether he's a wheezer of a long duration. All these things are signs. Eliciting the history appropriately is the art, and the science is reflected on your ECG. Then you go along with giving the adenosine or whatever treatment you want to give. That is science once again. The science. This is where the art and science of medicine get merged so beautifully that you need both for us to do a practice. And that comes with an empathetic approach to the patient. Rigid application of medical knowledge eventually runs out of options when it comes to preventing death or pain. The healer always has something to offer in the form of attention, understanding, compassion, and possibly even knowledge. This is where empathy is very, very important in your practice. Being sympathetic is different, but being empathetic is an art. Trying to feel what the patient is feeling and trying to give them the words of comfort and how they can scale over the ailment that they are suffering. Or even if it's going to be an irreversible process, that the disease is going to end in the end result. The compassion, the attention you are giving, understanding their family situation, understanding their feelings is definitely going to make you a good doctor to him and to his family. And that is where the art of clinical medicine is there. Empathy is seeing with the eyes of another, listening with the ears of another, and feeling with the heart of another. The art of multidimensional doctor. Doctor can assume a variety of roles depending on the desires and the needs of the patient, who are influenced by a range of elements like their social support, education, personality, degree of comfort, and familiarity with the medical system. If you are a family practitioner, you will know how valuable you are to the society. Somebody has a seizure in the family, a young girl, mature, getting ready for marriage. The question always will be whether this ailment is going to affect the offspring, whether what kind of a groom are we to look out for the girl that the family is not going to suffer from seizure. Seizure was once a cause for getting a divorce in a relationship, but today it has been changed in the last 5 6 years. But these are things I myself have counseled the family. Today, diabetes is one of the most common problems. They keep coming and asking, be it a male or a female, whether they can get fertile or not, whether they can get an offspring or not, is a very, very common system. Somebody who has got a timid idea fast in life, they want to grow fast. You always feel them trying to give a lot of history in your practice. They come in and they talk so many things. A guy might be going in for a college and what type of education they want. Sometimes, as a family physician or a physician for them for a long duration, they do come to you to get a social support on the education that the child or the son or the daughter would be opting for. These are things that the multidimensional way a doctor will have to perform to the society's needs. It's not only because that you are a highly educated in the society, the creamy layer of the society. It is also the way how you can assess the patient, find out which will be the much better job or education that the child or the son or a daughter could go in, and that is all an art of communicating your practice to them. The science have given you the reputation of the society. The art has given you the becoming closer to the family. That you try to give an information or a vital advice for the family to go on. Maybe after 20 years, they'll come back and say, because you said, doctor, that he will be a good engineer, or a civil engineer, or an electronic engineer, that he became, and now he's earning so much. He's fine in his life. He have achieved so many things in his career. These are all the art of clinical medicine, the art of this profession that is being beneficial to the society. You can perform in a multi-talented way, but your skill and knowledge is the one which is going to last long in the minds of the patient who are sitting in front of you or by your side. Patient typically place their trust in the doctor's scientific proficiency. No matter how polite a doctor became, that patient's trust in them will be damaged, and this will make if more difficulty to establish a therapeutic connection. Those claiming to practice the healing art, but lacking the necessary technical expertise, are characters, are not healers. The quacks, they have the good art of communication, but then over the time, the patient will be able to find out that that person is not qualified to treat you as a proper human being. There are times when you overlook, try to treat which is not within the purview of your specialty. Even that is also well recognized with the patient that they will find out that they have somewhere shortfall, that they will go back to a good specialist because Google gives them the information which specialists are available nearby. They go back, Google it, get a consultation, and come back and tell you the same. So be aware that don't cross the way beyond the scope of your knowledge, beyond the scope of your qualification, and try to treat a patient. You may land up wrongly, or you might lose the patient's confidence and trust that over the time you will feel for that. So better be within the limitations of your qualification and skill and knowledge, not exist, not beyond the limits. And this is the value of a temperature chart that is in clinical practice. 82 years male, admitted for loose stones, who's a known diabetic. When you are a known diabetic, you always have certain ailments that can always stuck with you. That to a person with almost 15, 16 years of diabetic in the age of 82. Vitals was normal, ascites present in the abdomen. Use history of loss of weight over 3 months and frequent stool disturbance. The differential diagnosis when you're 80 is always first is malignancy, next is malignancy, third is tuberculosis. And doing all the evaluation, the patient was found to be having abdominal tuberculosis. We did not go to the extent of trying to find a node. We went to the extent of trying to leave out, an exclusion diagnosis. We exclude everything. Even a PET scan was taken. There was no uptake. And then finally, since the patient is 82, the ascitic fluid was positive for ADA and all these things, we started the patient on tuberculosis. And the first symptom that comes down within 3 to 4 weeks is the temperature. Temperature chart of the patient is a very, very important tool in your practice for you to diagnose most of the fevers that do in the present day scenario of you have come to the monsoons of this country and You always have a spurt of viral fevers, spurt of dengue, lepto, malaria, and whatever it is. Your temperature chart, and you have a signs of temperature charts for each of the ailment, and each of the ailment also merges at that point of time. Clinical examination as well as diagnostic tools will be of very use to find out and teach the diagnosis. Temperature chart is a valuable tool in your clinical practice to find out what the patient is suffering from with the science that has given us temperature status for different ailments. I think that will be the last slide of listening communication skills that is very active. Body language, good manners, good message, empathetic listening, and all these things are there in that one single side. And a combination of all these things is a good doctor who has the science of medicine, art of communication, and that is what we want to produce in the society for our population to live hale and healthy, to have a good India. And I thank you all for your artistic listenings. And this topic was taken mostly from the art and science of clinical medicine, the factors that make clinical medicine more effective. And Lakshmi Narayan and Bairi and Shakta Mani Satyam, the two contributors for that article. And most of the clinical cases were my own, plus Dr. Sarath Balaji, who was the pediatrician, treated that patient for 3 months and then saw the patient again after 11 years. Thanks to every one of them, and thanks to you all for your patient listening for a subject which is far away from the medical practice, but too close for your successful practitioner, the art and science of clinical medicine. Thank you all.
Thank you so much, sir. Thank you for your such impressive talk that you have shared and for making us understand about the art and science of clinical medicine in such a beautiful manner with all your PPT presentation that you have shared on our platform. Thank you for making us know about the importance of skills, good mannerisms as taught from you. Thank you so much, sir. Thank you. Moving ahead with the question and answers round, sir, we have received few questions from the participants. With all your due permission, I would like to put across those questions to you. So the first question is related to the situations where multiple treatment options are given. So in situations with multiple treatment options, how do you integrate between both evidence-based guidelines and patient preferences to make the best clinical decision?
Evidence today, evidence-based medicine, because we got to defend ourselves legally also. If we need to defend ourselves legally, as well as give the best of treatment to the patient, is evidence-based medicine. Your clinical correlations will be correlated along with the evidence base. That is what the last patient of tuberculosis. Temperature chart gives us that evening rise of temperature, sometimes random rise of temperature, then finally evidence of the ascitic fluid giving a positive result toward tuberculosis is favored. Today, without evidence, patient is not going to trust you even if you have a good quality of communication. The communication has to be that you need to do the evaluation. Quite a number of times, patients will be unwilling to follow that advice what we give. They always try to find out somebody has been started on ATT without doing certain investigations. Pulmonary tuberculosis is different, abdominal is different. All these things will have to be communicated to them. That is where today evidence-based medicine is the need of the hour to defend your profession, defend yourself legally.
Thank you so much, sir. Thank you for answering that question. Moving ahead with another question that we have received, and the question is related to the factors. So, what are the key factors to consider when interpreting diagnostic test results in the context of a patient's overall clinical picture, especially when results are inconclusive or borderline?
Nothing went wrong.
Yeah, not a problem, sir. I'll repeat the question once more. So the question is that what are the key factors to consider when interpreting diagnostic test results in the context of a patient's overall clinical picture, especially when results are inconclusive or borderline?
Of course, this is a tough one to decide in your practice. Uh, Somebody who comes, your thoughts process will have to be there. If it's going to be an acute ailment which needs an intervention, you need to convince the patient to go in for an evaluation. You need to tell the patient if the evaluation is not done, what are the side effects of complications that can happen. If that happens, it will be very tough to come out of the whole situation. Take for an example a pain abdomen. The patient will not be willing on the first day to do an ultrasound abdomen. You do the clinical examination, you find the pain to be more, which we expected to radiate to the right iliac fossa in another 6 hours, or 12 hours, or 18 hours, or whatever it is. But then you need to tell the patient, looks like an appendix for me, and I would be happy if you do an ultrasound now itself. But then, if he resists for it, please don't give a painkiller which is not the norms, which is not in the protocol for an appendix and it's suspected. Then give him some placebo, reassure him, advise him for the investigation that you want to do, at least on the prescription that is there, so that legally you are supported for your thought process that is towards an appendix. And then tell him if the pain recurs another 1 hour, 2 hours, to do an ultrasound, then reach the hospital where you can get admitted or come back to me or call back or send me the report on a WhatsApp. Today, digital technology, I am not for a telemedicine or teleconsultation. That means I'm in support of trying to communicate on the WhatsApp or digital mode of communication. If it is not going to be an acute problem which can wait for some time, you can always try some medication. Advise them to wait till we do an investigation, or advise them the investigation and ask them to do it whenever the pain recurs or the symptom recovers and whenever he feels comfortable. Most of the time, it is money that always matter, and occasionally it is the unwillingness to undergo the investigation. Today, patients have gone in a different mode. They do all the master health checkups and come to the clinic and say, "This is my master health check, right?" And come to companies, the IT companies, ask the people to do their investigation at least once in a year to keep them fit, because they overutilizes them physically and always mentally. The IT industry is always paying you quite handsomely, is not for anything, but then to get the best of work out of you. That is why they always ask you to do some evaluation. So that tomorrow you should not blame the company that they have overutilized your facility.
Thank you so much, sir. Thank you for answering that question. That was the last question for today's session. Okay, I think there is some network connectivity issue, sir. Can you hear me, sir? So, are you there? Hello? Yeah, sir is
And
back with us. So, yeah, no, not a problem, sir. Thank you so much, sir. Thank you for answering that question. That was the last question for today's session. And I would like to thank all of our viewers for their ardent participation that they have shown by staying tuned with us throughout the session and putting across such interesting questions to us. So, thank you to all of them. And before we conclude, sir, any last take home message from your end before we conclude?
be a good artist with all scientific knowledge of medicine. You will be a very successful practitioner in your life. Thank you again for the opportunity.
Thank you so much, sir. Thank you for your valuable time. And with this, we would like to conclude the session here for today. Until next time, and I would request all our viewers to stay tuned for the next session. Thank you so much, sir. Thank you.
Thank you. Thank you. Thanks a lot.